she'll be presenting a headache strain and ophthalmologist strain. Great.
Good morning, everyone, and thank you for having me. As I come from a multi-speciality hospital, I noticed that patients with headache usually go to an internist or a neurologist. So this is my case against that. So usually, headache, as we all know, is a common universal symptom. It leads to a lot of absenteeism, loss of work hours. WHO says up to 40% of people do have headaches in their lives. But there are diagnostic issues. It's multifactorial. There are varied etiologies and classifications. And it spans along many specialities. So it's the internist, the neurologist, then the ophthalmologist, the ENT specialist, they have a claim to headache. Then there's a psychiatrist, the orthopedician, the dentist also. Now even the anesthetist, the neuroanesthetist and the analgesia specialist, they lay claim to headaches. So since most of them are benign, can be treated with minimal workup, but some of them can be vision and life-threatening, and they can present as headache. So they need to be diagnosed in time, and the patient himself sometimes doesn't know where to go to, whether he should go to the ophthalmologist or the neurologist. Usually these land up getting investigated too much of neuroimaging, CT scans, MRIs, where it could be as simple as computer vision or digital eye strain, or something as simple as a refractive error, uncorrected hypermetropia. So, but there are very limited studies which show what is the distribution of this pattern of referral. And there are ego issues happening in every specialty. Should we refer to the next specialty, etc. So, since we didn't find anything much on the net, we thought we'll do at least a pilot study before I come and speak about this to you to put forward my point. So we did a small pilot study spanning 2 weeks. In the first week, we saw the existing distribution. And the second week, we decided to send all patients having headache first to Ophthal and then refer them as required. So this is in short for this slide. So this was part 1 and part 2. So all patients, new patients coming to the screening OPD. Now in our hospital, there are 2 ways for new patients to come in. One is through the screening OPD, where the nursing officer gives chits and sends to the respective departments. And the second is through self-registration on the kiosk or the website. So there are 2 ways: the nursing officer decides or the patient himself decides. And then we see how many are referred to ophthalmology. Old patients or existing or known cases of glaucoma or other headache diagnosis were excluded. So we had this partly in the screening area and partly in the Ophthal OPD. As I said, first the patient came to screening. The nursing officer in the first week gave a token for whatever she was known to give for existing departments. The specialist saw the patient, and either treated or referred to Ophthal. And some were directly referred to Ophthal by the nursing officer. This second week, we said send all to Ophthal. And then we saw the patients, and we referred elsewhere if we needed, or we diagnosed. So we wanted to know the pattern difference also. So this is the first week statistics. The gender, well, a little bit of a female preponderance. 4% of all patients who came to screening, and around 1/3 came to screening, 2/3 came through self-registration. So, and this is a hospital with 32 departments. So 4% is quite a sizable number. So, and these were the patients we referred to other departments because they didn't belong to an ophthalmological diagnosis. So these were the 3 categories basically. Those coming from screening, those who self-registered, and those who other departments referred to us, which incidentally happens to be very less. And this is what I want to stress upon. So here, the screening staff decided, the patient decided, and in the 3rd category, the specialist decided. So in the first, so this is the diagrammatic representation of that in the first week. So where the patients came from screening, we saw that they referred only 70% 19 out of 100 patients to ophthal in the first week. So that was very less, but amongst them, 75% did have an ophthalmological diagnosis. Amongst those who came themselves, 68% had an ophthalmological diagnosis, and we had to refer the others. And amongst those who were referred by the specialists from the other departments, all of them had an ophthalmological diagnosis. So this was in the second week. So percentage was around 3% this time. We had them all sent to ophthal. This is the comparative. There were no referrals this time from other departments. So 20 came as self-referred, 39 were from the screening OPD. There were some lost from between screening to ophthal department. I'll just talk about that. From screening, 52% had an ophthalmological diagnosis. Self-registration, 39%. This was week 2. And this is a comparative of where all we referred the patients in the 2 weeks. Now, this is what I would like to show. If we divide it, this is how it is, the division of how many had an ophthalmological diagnosis in the first week, and this is as per percentage. What I'd like to show is, in this case, those coming from screening, only 14% in week 1 of all screening patients got an ophthalmological diagnosis totally, because out of 100 patients. And in week 2, 54% of them had an ophthalmological diagnosis because they were all referred. So 40% are somewhere being misdiagnosed or not referred to ophthal for an ophthalmic cause. And in both the weeks, the patients who came themselves scored high, quite high. And the limitations of the study is that it's very small, the sample size. Tests of significance could not be applied effectively. Some days or weeks can be heavier in the OPD, especially after holidays and festivals, etc. And weekly holidays are, I just have 2 more slides, if you can please continue. But there was a dropout between screening to our OPD. We could see only elective and new presentations. We saw that the screening division was least accurate. Patient himself was more accurate, and possibly because he was more aware, he was more techno-savvy, and possibly he had more incidence of headache because of that, because of digital eye strain. We don't know that. That could be a confounding factor. And the specialist is the most accurate, but the least of the component. The specialist referring to ophthal, another specialist, is the least common. So there could be a bias. So overall, I would say, concluding, 50% patients were diagnosed to have ophthalmic causes of headache. The ophthalmologist's role is not only diagnosis and treatment, but also referral to others. And there should be a very strong referral to and fro established. Spreading awareness among patients can really help. Multi-speciality centers need to be developed, and eye-related causes are more common than brain-related causes. We tend to over-investigate headaches. SOPs need to be in place. We can have elective postings. In my institute, we've started elective postings in internship. We can have fellowships, centers with multi-speciality consultants, and international presence for headache in India, which is lacking. Only 1 person in India is registered in the International Headache Society. Headaches, first visit internist, very few get an eye referral, and we miss the glaucomas. We miss a symptom till it becomes a sign, and a latent error finally gets manifest. So it's time to see headache in the eye, quite literally. Thank you.
Thank you so much. That was very enlightening. And I agree that we tend to sort of underestimate the headache part, especially it's like no one's baby. Yeah, investigating more into it is very crucial. So,
Dr. Puja, what was the most common cause of pure ophthalmic cause of headache?
So here in our case, the most common was refractive error, digital eye strain, computer vision syndrome. These were the most common. I have put them up, but I think because of lack of time.
And which refractive errors were the most common? What age group are we looking at?
In pediatrics, we had the least referrals actually, just 3. And because there's a neuropediatrician with us in the pediatrics department, So the least was for pediatrics, but this was for adults. There was
actually,
myopes,
that's why I saw.
astigmatics, as well as hypermetropes.
Okay, and
We have a short stature in Maharashtra, so it's a little commoner than elsewhere with the taller people with hypermetropes.
okay, sure. Because I personally, at our center, I found it a reverse problem. I find that our neurologists keep referring us headaches, and essentially we're looking at, of course, the most common causes being orthoptic related problems, eye muscle
Orthopic
problems,
also,
and
yeah.
to a modest extent, refractive errors, although, I mean, probably that's not the primary cause for them having a headache, but yeah, ocular surface disorders also with the periocular eye ache. But yeah, absolutely. We do need a little better understanding of headache as a more localizing or an understanding value.
There was
Thank you.
also a trend towards having more PIs done, especially not in this particular pilot study. It didn't get documented here, but I had tried this before and I asked the screening officer to send me more, and suddenly the number of peripheral iridotomies like increased.
Yes, so
And
those
one
two
more
weeks,
thing,
so.
if you're dealing with children, actually we get more referral from the pediatricians. Just anyway, they will refer. We have seen any headache, they will refer to you, and you have to do a orthoptic workup. You have to do
Orthoptic,
a refractive error correction in that. That is more common. We have seen in our
So
centers.
we've seen that certain
And
pediatricians do
neurologists
that.
will be sending those cases, and even patients, they come to you with headache with other symptoms, you will yourself diagnose and have a referral. So these are the more things, more of a headache which is going on, and ophthalmic migraine and all, these are all, there's a interrelated work which
I
should be
think
going
we'll
on.
take the discussion after we finish the session.
Sure.